Bonjour tout le monde. Je m'appelle Ashok Mala, je suis professeur de psychiatrie à l'Université McGill. Malheureusement, je dois présenter ma conférence en anglais parce que j'ai seulement 20 ou 25 minutes. C'est plus difficile à faire en français. Okay. Thank you, Mary Odile and Julian, for inviting me to do this presentation. I will try to be brief, even though the subject matter is actually very long and very deep. So what I'm going to do is just give you a very brief overview of what I think could be done to get better outcomes in psychosis through early intervention. So I don't have any particular conflicts of interest. Most of my funding comes from publicly funded research programs. So what I'm going to do is cover three areas, and the first two are going to be very brief, and most of my talk will be on the third objective. First, I'll provide a very quick historical review of how we got to where we are in early intervention service. Both research and service. Then I'm going to review briefly the limitations of what the current early intervention services have, and that prevents it from getting more benefit for patients from this amazing reform in health services. And then I will the second half, or more than second half of my talk, I'll talk about what I think are the areas where we can improve and how we can do that. So let's just put it in some context. We know that the lifetime risk of psychosis is actually not that small. It's 3.5%. But more importantly, it's really essential that we recognize the enormous variation in incidence rates of psychosis, both in terms of age groups as well as geography. It ranges from 8 to 43 per 100,000. And we did a study a few years ago. One of my PhD students many years ago did a study in Montreal, confining ourselves to this age group of 14 to 25. And as you can see, the incidence is extremely high. So this is relevant in planning services, and I'll come back to it a bit later on. So just a historical perspective, I think the modern era of early intervention really started with Judd Wyatt's observation when he reviewed many studies and reviewed charts of patients and observed that those who had received treatment earlier seemed to have done better. I mean, it seems now what would be obvious, but at the time it was a bit of a revelation. And then I think we mustn't forget the contribution from Ian Falloon, whose equally strong contributions were in the work that he did with family intervention. But he did an amazing study that no one has ever replicated or even tried, where he actually showed in a small community that you can't prevent schizophrenia from occurring in terms of its full threshold caseness. And I won't go into the detail. People who are interested should really look up this work way back 30 years ago. Then Max Birchwood's hypothesis of critical period, I think, had a very big influence, and I'll get into that in a bit more because it is one of the things that drives actually the early intervention service reform. We got interested in actually the delay in treatment, and about 20 years ago, we published some work on trying to understand this concept of duration of untreated psychosis. And I'll keep coming back to this because it is a really critical part of early intervention. And then Pat McGorry, and following him, several of us published what a program should look like that provides this early intervention service. So as a result of all of this, what we have, or what we have had in the past more than 2 decades now, I've been doing this work for almost 25 years, that there are essentially two components of early intervention service in psychosis. The first part, which is the actual content and quality of treatment, is extremely important, even though it wasn't what got the early intervention started. It would not have made any sense if we simply just brought the treatment forward, in other words, provided early, but didn't actually change the content of the treatment. So the first component of early intervention services is essentially a comprehensive, very phase-focused, evidence-informed interventions put together in a package. There's not a one single intervention that works on its own, but putting it together as a package and using a systemic approach that is very patient-oriented, recovery-oriented, and focused more on the community than the institution. In general, there is actually very good fidelity to this aspect of early intervention service. The second component, and equally important, is actually reducing delay in treatment and providing treatment early. Unfortunately, there's relatively low fidelity and low uptake of this. This will be actually a big part of my talk. Here is a kind of a typical, this is our specialized early intervention program, PEP, but it's not unlike many others, like the Australian program, where you have a comprehensive array starting all the way from early recognition, early case identification, to a very thorough assessment, and not relying on physicians entirely, that it is a multidisciplinary approach, but a team approach. So you do a proper assessment of symptoms, functioning, quality of life, cognition. And then at the bottom, as you see, are these multiple interventions put together as a package. Some of them are necessary for everybody, like pharmacological treatment, pretty well for everybody. Family intervention, I'll come back to that later on, in my opinion, is also essential for everyone. CBT, when it is required, roughly about 30 to 40%. And psychotherapy, I think, is more or less essential for everybody. So what is the evidence we have? I think we have now more than sufficient evidence from several controlled studies as well as uncontrolled studies to show that this kind of model, and this is without actually reducing delay in treatment, leads to higher rates of remission, symptomatic outcomes are better, lower rates of relapse, lower substance abuse, better overall functioning, and importantly, it's cost effective. One thing I don't have it there because the evidence is not perhaps as strong, but I think it's there that the suicide rates from early intervention services are significantly low compared to lower compared to the regular care. So now we have all of this, then what are the concerns? Some of us believe that the benefits of early intervention psychosis are underutilized, and I'm going to now go through the main part of my talk, which is really what are those sources of underutilization and what can we do about it. And I've just listed some of them. First of all is the failure to reduce delay in treatment. Second is that the programs set up have not actually penetrated the untreated prevalence, therefore have had a limited impact on population level. Pat McGorry and I wrote a paper last year in the American Journal of Public Health, where we have actually concentrated particularly on this, but also touched upon some of the other issues. I'll talk briefly about disengagement, and we don't actually know exactly how much and for how long early intervention should be given to whom. And then at the end, I will quickly touch upon the potential of treating high-risk states. So let me first deal with the whole issue of delay in treatment and how can we reduce it. WHO and the International Early Psychosis Association had recommended a few years ago that a DUP of 12 weeks or less for all incoming patients is what should be the target. They had no particular evidence to support this. I think it was just it was more kind of an expert opinion. On the other hand, DUP ranges, duration of untreated psychosis ranges from 4 to 6 weeks, median of 4 to 6 weeks, to more than 1 year, even in early intervention services. In Britain, for example, where probably it's the most advanced scaling up of early intervention services, up until a couple of years ago, they hadn't really paid much attention to it. And I won't go into detail of that. Be happy to discuss it if there's an opportunity. Then we have additional evidence from the Danish Opus 2 study, which is the extension of early intervention service. There's a hint that patients with DUP of less than 12 weeks did better in the 3-year extension. The problem they have is that their DUP is so long that very few patients actually met this criteria of less than 12 weeks. Then we have the fantastic study, the TIPS study from Norway, where they actually experimentally reduced DUP, brought it down to about a median of 4 weeks in the experimental sample, and 5-10 years later showed that these patients actually had better outcome on negative symptoms. And a similar to the Opus, the RAISE study in the US also demonstrated better outcome for shorter DUP. But as you can see, even shorter DUP for them is extremely long and much too long. So I'll show you very quickly the results of, we did a randomized controlled trial between 2009 and 2015 of extension of early intervention services beyond 2 years, comparing 5 years of early intervention service with 2 years of early intervention plus regular care, 3 years. Within that, what we also examined was this issue of DUP. Fortunately, our median DUP was around 12 weeks, so we were able to split the sample equally between the two. And these were the results that were published just a couple of years ago, that patients with a DUP of less than 12 weeks or less experienced a much longer negative symptom remission, which was our primary outcome in an extended early intervention service, compared to those who had a DUP of greater than 12 weeks. In fact, patients with more than 12 weeks DUP actually did not benefit much from extending early intervention service. And this was independent of any other factors that we know that influences outcome. Now, recently, from the same study, we just published an economic evaluation of extended early intervention service versus regular care. And what I want to show you is patients with DUP of less than 12 weeks are the ones where even economically it makes more sense. So in the top part of this slide, you see when the payer, which in our case is the government, the public insurance, is not willing to pay any extra dollars for early intervention, the patients with DUP of 12 weeks or less maybe are marginally economically feasible. There's some cost benefit here, but patients with over 12 weeks DUP, it costs a lot more. However, if the payer is prepared to pay $2,500 per patient per year, you can see the enormous benefit patients. These are the ones in the triangle. With the triangle, these are the patients with DUP of 12 weeks or less, and you can have a range of anywhere from almost $7,000 to $21,000 benefit. But for patients who have DUP greater than 12 weeks, even investment of this money actually gives very little benefit. This is the net monetary benefit from the investment. So I think this kind of confirms that DUP is extremely important and that we have neglected it. So what is the way to get out of this? First of all, we need to understand what is, how do we understand this DUP, duration of untreated psychosis, which is the measure of delay in treatment. First of all, we need to understand that there are different components of it, and each component may be driven by very different factors. The help-seeking delay, which is from the time of onset of psychotic symptoms to first contact, to help-seeking contact, so that's one part. Then once you make that first contact, there is a delay in the system before you actually get into an early intervention service. And even when you're finally referred, there is an administrative delay that varies across programs. So what I want to very quickly show you is now that we have these components, we can look at what drives each of these components. And I'm not going to go into that detail because of lack of time, but what is important is to know what is the pathway, what is the trajectory of care that patients go through where we can intervene. Because really help-seeking delay is much harder to manipulate, but systemic delay should be within our jurisdiction to make an impact on it. So the first thing we need to do is understand that first episode psychosis patients don't usually seek for treatment for psychotic symptoms at the beginning. They mostly seek treatment for anxiety, stress, depression, sadness, sleep problems, difficulties in concentration, distracting thoughts, and I've given you the percentages here. And about 1/3 of patients, it's actually the families who seek treatment on their behalf because they find these young people irritable, their behavior is disruptive, or that they are socially and interpersonally withdrawing. The other facts we need to know about the system is that patients, actually 1/3 of patients do seek help before they have full-fledged psychotic symptoms. So there's obviously, we know that during the prodromal period, patients are actually suffering and are going through many sources of distress, and 2/3 seek help after the onset of psychosis. The interesting thing is the most frequent first contact is with the family physicians, but that is not the source of referral to the early intervention services. This is at least the Canadian scene and the British scene as well to a large extent. So most of them still enter treatment through emergency. And patients who are making healthcare contact before they have an onset of psychosis seem to have no different pathway to care. In other words, they ultimately end up the same way entering into the treatment in early intervention service as do those who have onset, who are seeking help after the onset of psychosis. So there may be some missed opportunities here that could be taken advantage of. So what do we do? What is the intervention? And this is what we have done over the last 20 years and reduced our DUP, systemic DUP considerably. It's down to about a median of 1.5 weeks. So we need to simplify the pathways to care, and that is done by making referrals access free of any referral source, and that it should be rapid within 72 hours. And let me give you a case example. There is a 15-year-old boy in school, high school, who seeks help from a school psychologist for anxiety, difficulty sleeping, and he also says that he occasionally hears some noises, a voice, but it doesn't stay. And he is stuck for 7 months with that psychologist before the psychologist realized that this is something different than what she can handle. And then there is the whole trajectory from one emergency to another, to primary care, and finally to the ultra high risk clinic and to early intervention. And this takes 16 months, which is much too long for a 15-year-old. And here is what should have happened. There should be a system that the school psychologist picks up the phone, has a direct contact and knowledge of the early intervention service, and says, hey, I have this young boy, I don't know what to do. Here is the situation. Can you advise me? And then that would get the process going. So the practical implications are, and we published some of this, and one of our students has published a review of this. The referral system needs to be open. In other words, there should be no referral required. And anybody should be able to refer. And then the first point of contact, and this is the system we've operated with, should be a well-trained clinician, a non-physician, to whom anybody has access from any source. Of course, you could say, well, the person could get overburdened very quickly,
but a lot of it can be sorted out on the phone to say what's appropriate, what is not appropriate. And then there has to be a psychiatrist who's committed to the program, available very readily. So that's the one source, I think, of underutilization of early intervention. The second is that we clinicians, I think, are really, really good at treating the patient who comes in to see us. We're not very good at wondering what happened to the one who never got there. So what we don't have is a population level approach. So the same PhD student, Kelly Anderson, now she's on faculty. She's an associate professor at Western University in epidemiology. And she did this fascinating study where she showed that for every one person who gets into an early intervention service, there are one or two who never get there. And the consequences of these I will show you in a minute. And here, this gives you a picture of if you, this is using administrative data. This is the program I started way back in 96, 97 and left in 2003. And this is the program that she has investigated the data from. And you see that the total estimated incidence in the community was 90 per 100,000. 50 per 100,000 were actually referred, and only 19 per 100,000 actually got treatment. And of course, the age curves are as expected. The biggest bang from the study published in the American Journal a couple of years ago was that patients who got into early intervention had 4 times less mortality than patients who didn't get. And there is not a bigger and a better outcome than reducing mortality. And here are the actual data. And you can see these ones here are the users of the early intervention service, and these are the mortality rates, and this is all-cause mortality, and these are the patients who never got there. So what is the number? So if you treat 40 cases, you're saving 1 life, and I think that is a pretty good deal. But obviously, programs, even good programs like the PEP in London, did not manage to do that. The third issue is the how long should patients receive services. It's not so much only the issue of how long, but who should receive it for 1 year, 2 years, 3 years, 5 years, and this has to be sorted out. There have been several studies, randomized controlled trials, looking at extending early intervention beyond 2 years. And I'll just very quickly show you the results. Our own study that was published in World Psychiatry, we showed that if you extend early intervention service from 2 to 5 years, you get lower attrition rates in the early intervention arm, longer time in treatment, longer time in remission of positive and negative symptoms. Hong Kong study had similar conclusions. And as I said earlier, it is influenced by DUP. In other words, patients with DUP of 12 weeks or less are the ones who are benefiting from it. But most importantly, the point I want to make here is that half of the patients were obviously randomized to regular care, and among those, half went to primary care and half went to specialist non-early intervention care. So the important thing here is that the patients who went to primary care did actually as well as patients who stayed in early intervention. Why? Because they were matched. Before randomization, we had discussed with patients and decided that the patients who looked like they had a good outcome in the first 2 years didn't need intensive treatment. So what that means is that we need to investigate that there is a subgroup of patients who actually need more than 2 years of care, and the other could probably do as well in a well-established primary care. So that's, that basically speaks to the need for studying specificity of the length of treatment, because at the end of the day, every program has limited resources. So if you get bogged down with everybody staying 5 years, is going to be a bottleneck at the entry. The fourth issue I want to talk, and it's very simple, and that is family involvement and family support. Grossly neglected, especially the involvement of families in day-to-day patient care in the program, as well as actual family interventions. Very low uptake, even in early intervention services. We know, I'm not going to go through this, there is probably not a better subject to pick up if you want to look at evidence, and this is reduction of relapse rates by more than 50% with the family intervention. What I want to show you is that some recent lesson we have learned from a study that we just finished less than 2 years ago, comparing outcome in first episode psychosis between an early intervention service we established in Chennai, what used to be called Madras in India, and our program in Montreal. And just one of the first papers that have just come out of looking at comparison of clinical outcomes. And I want to show you here, we have almost equal size samples, 165, 168. And here, one of the first measures is that how many months of contact did the patient's treatment team have with family? And as you can see in Chennai, everybody had contact every month. And in Montreal, it's an average of less than 12 months out of the 24 months, so half of the time. So there's one finding. The other is that family support over time increased in both settings, but it always remained much, much higher in Chennai, in India, which speaks to the fact that if family support has any impact, then it is going to be greater where the family support is higher. And we saw that actually, I won't actually, what basically this graph shows, this table shows, is that the outcome on positive symptoms was better in Montreal, but that was really a regression to the mean. But the outcome in negative symptoms was better in Chennai. And as I have summarized here, that was partially, not entirely, but partially accounted for by higher level of family support. So there may be something to learn, what kind of like reverse engineering, what sometimes people refer to, from a different cultural context to do things differently in our own programs. And families are important everywhere. Just almost to the end of my presentation, disengagement, it is still quite high. 20 to 25% patients disengage from even early intervention services. So we again examined this in the context of the same study, a paper just published in Psychological Medicine, where we looked at disengagement rates in Chennai early intervention service and in Montreal. And here you can see almost no one disengaged, even though they didn't actually come to see the case manager or the psychiatrist every time, but they kept contact on the phone, email, whatever way they could. And here you have a disengagement rate of around 15 to 18% in the case of Montreal. And the interesting thing here, again, we found that family support was one of the drivers of this. This is an interesting graph. What actually, even though it looks complicated, what it essentially shows is that this is the family's contact with case managers. As you can see, this is totally in Montreal. At the beginning, it's high, it keeps going down. And then families, the green is the one the families are not in contact, but the case managers think they should be. But the most important finding is the red, which is that families are not in contact and the case managers don't think they need to be in contact. They're not, it's not necessary. And that keeps going up over time. And yet we have seen is that family support is important throughout if you want to maintain better outcome. So last point I want to make, and I'm not going to go into detail because it's a subject by itself, is does clinical high risk have a role if we treat patients in clinical high risk? We know that the response is good. Non-pharmacological treatments have as good an outcome. The question is, how can we incorporate into the system of early intervention care? The issue here comes that clinical high risk work is almost entirely research up until now. But here's the definition of clinical high risk. Most of these people have attenuated psychotic symptoms, so I won't go into that. The utility is what is important here. Can we actually utilize clinical high risk states for developing service? So the question there to ask is not how many people who have clinical high risk develop a full-fledged psychosis, which is what has been the focus, but how many people who have first episode psychosis have gone through a clinical high risk state when we could have provided them potential benefit. And the answer to that is 48 to 67% of patients who come eventually with first episode psychosis had gone through a clinical high risk state. We published some of this work, and I think this is an opportunity to say that if we create clinical systems where some of these patients can be picked up then, and you will recall earlier in a slide I showed that vast majority of patients actually present with non-psychotic symptoms at the beginning, and 1/3 actually seek help before the onset of psychosis. So this is an opportunity that we really can make use of. So just to conclude, I think right now we have this specialized early intervention services, the dominant model that's been scaled up, but we may want to look at some other models that might be better or equally good for patients who have generally good outcomes. So the evidence is very strong, but it's mostly confined to high-income countries and especially publicly funded system. As I showed you, the early intervention services is not accessible to a large proportion of the population, which really inhibits its benefit to a larger part of the population. People are setting up early intervention services without direct regard for the population-based data. And I think that's going to be extremely important because it will vary, incidence will vary from community to community, pathways to care will vary, and all of this will need to be taken into context if you actually want to reduce DUP. I also mentioned a couple of things about that there may be a need for finally, precisely figuring out how long early intervention service should be given to what kind of patients and which patients can actually move on to other levels of care. And finally, high-risk states we need to figure out a way of bringing in clinical high-risk states into a service model, and that's a challenge, and we need to meet that challenge. And we also finally, I think we need to extend the early intervention model to all mental disorders so that we're not working in diagnostic silos. So I want to finish there. I want to thank you. Merci beaucoup. S'il y a des questions, je pense que je vais répondre pendant la conférence. Merci.